Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. In this episode, we will be hearing pharmacists' perspectives on the latest data on HIV care and prevention, specifically long-acting ART and long-acting PrEP from AIDS 2024. I'm joined today by Dr. Jennifer Cocohoba, Professor of Clinical Pharmacy at UC San Francisco School of Pharmacy in San Francisco, California, and Dr. David Koren, Clinical Pharmacy Specialist at Temple University Health System in Philadelphia, Pennsylvania. For more information about this program and to follow along with the slides and to register for one of our live sessions in the series, please visit the links in the show notes for this episode. And to get access to all of our new podcast episodes, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Now, let's get started and hear from Dr. Koren.
Good afternoon, everyone. We have a lot of very exciting information to get through today, and we're going to be starting our discussion with the study that was presented at the recent conference, the first PURPOSE trial. So we're going to start our discussion with long-acting PrEP. So PURPOSE 1 specifically was looking at twice yearly lenacapavir, our capsid inhibitor, injections versus daily oral tenofovir as PrEP in cisgendered women. Now, it's interesting because as we take a look at the clinical trial design, this was a randomized, double-blind, phase 3 clinical trial that was done primarily in South Africa and Uganda using a counterfactual design. Now, for those who are unfamiliar with the counterfactual design or why we would even need to do a trial design like this, I want to present the 2 hurdles you need to do when you're looking at this patient population as we study PrEP. The first is you can't really use a placebo when we know we have an intervention that works. The second is if we look at the breadth of clinical literature looking at PrEP interventions in cisgendered women, there have been significant hurdles in terms of adherence. So we need to make sure we're comparing against an actual effect. So a counterfactual design is actually going to compare against a background incidence. This kind of design actually comes from the contraceptive world. So who was included here? Cisgendered women who are aged 16 to 25 years of age, who are sexually active with cisgendered men, and greater than 1 vaginal intercourse within the last 3 months who are not pregnant, an unknown HIV status, and no HIV testing or PrEP or PEP use in the last 3 months. They had to have been greater than or equal to 35 kilos with good renal function, and of note, there was no contraceptive requirement. Patients could be on the contraceptives if they so choose, but there was no specific requirement. And they were randomized in a 2-to-2-to-1 fashion. So first arm got lenacapavir subcutaneously with the 2 loading doses every 6 months or every 26 weeks, plus a placebo of either FTC-TAF or FTC-TDF. The second arm was receiving TAF-FTC orally with a placebo of lenacapavir. And this is important and interesting because this is really the first time we're looking at FTC-TAF in the cisgendered female population. The third arm looked at FTC-TDF orally plus the placebo of lenacapavir, again, every 26 weeks. And when creating the clinical trial design, there was always going to be a pre-specified interim analysis when 50% of the participants completed greater than or equal to 52 weeks of therapy. And based on this interim analysis, the DSMB actually decided to stop the study early because of the results that we're about to get to. The primary analysis, again, coming back to the counterfactual design, we're looking at lenacapavir versus the background incidence of HIV in that population. So we're going to screen a bunch of people, see what the incidence is in that population, and then screen against the intervention. We're also looking at TAF-FTC versus that background incidence as well as part of that primary analysis. The secondary analysis, Len versus FTC-TDF HIV incidence, and FTC-TAF versus FTC-TDF HIV incidence. And taking a look at our results, the background incidence, so approximately 8,000 people were screened to be in the study, finding that incidence rate of 2.41 per 100 patient years. And using the modified intent to treat population analysis, there were absolutely zero new HIV infections in the lenacapavir arm, showing statistical significance, as you can imagine, of decreased HIV incidence versus that background. But then when we take a look at TAF-FTC, the rate of 2.02 was actually determined to be statistically similar to that background incidence. And you're looking at this and you're saying, well, did TAF FTC work? We then have to ask, were people actually taking the medication? Remembering what I said previously, that there have been issues looking at PrEP interventions with adherence. If you don't take a medication, it's not going to work. So as we said before, on the bottom, there were 0 HIV infections that occurred in cisgendered women receiving LEN. And in the oral FTC TAF arm, HIV incidence did not differ from the background incidence, but treatment adherence was poor. And I'll get into how that was measured in just a moment. So what we can measure are, were injections actually given? This is something you can absolutely tell. And so at 26 weeks or 52 weeks, injections were given on time about 92, 93% of the time, which are great numbers. And that on-time injection rate was similar for LEN and placebo. Remember that everyone was getting an injection, and this did not differ whether or not it was the active drug or not. Adherence to the oral tablets was defined as being low because patients were actually having levels measured through dried blood spot analysis. This was measured for both FTC TAF and FTC TDF concentrations, arms, and this declined over time, which is what we generally see in clinical practice, that as time progresses, adherence tends to drop. Pregnancies were common and the outcomes were similar to those expected for the population. But let's take a look at injection site reactions, which we know can happen with lenacapavir, as was seen with other lenacapavir clinical trials. Nodules were reported with lenacapavir administration. However, the vast majority of these were grade 1 and they decreased as time progressed. Some pain, minimal pain and swelling were reported, as can be seen in the clinical trial. But of note, there were over 25,000 administrations of medication, and only 4 injection site reactions actually led to treatment discontinuation. So now let's turn to the HPTN 084 clinical trial. Now, for those who remember, the HPTN 084 clinical trial was actually looking at cabotegravir for PrEP in cisgendered women, and this was an open label extension of a safety evaluation for long-acting cabotegravir during pregnancy. This was an international, randomized, double-blind, phase 3 clinical trial with, and again, open label extension in pregnant individuals who were offered the choice of long-acting cabotegravir or FTC-TDF from 2022 onwards. And as a very brief reminder, sexually active cisgendered women who were aged 18 to 45 years without HIV and with high risk of HIV infection. They were randomized to get either cabotegravir or TDF. And then they were offered the choice after the trial was over to either go to cabotegravir or TDF as well. However, in patients who were determined as pregnant, which was confirmed by 2 separate urine samples on the same day, they were randomized and given a choice because they had to consent to be in this portion of the clinical trial. Did they want to be on FTC-TDF by mouth, or if they so consented, to be on long-acting cabotegravir? And there were normal follow-up safety monitoring pieces, as can be seen in generally most pregnancy clinical trials. We had the primary outcomes were pregnancy incidence, maternal adverse effect incidence, individual composite pregnancy outcomes, which included birth, including a bunch of sub-outcomes, including spontaneous abortion or IUFD, stillbirth or premature birth or small gestational age, as well as infant outcomes as well. And we see the same rates of full-term birth from active cabotegravir versus no cabotegravir. We can see some reported rates of preterm birth, stillbirth, and spontaneous abortion, as can be seen in the remainder of the chart. However, across non-randomized exposure cabotegravir groups, these pregnancy outcomes were consistent with expected background rates of preterm birth, stillbirth, and IUFD, as well as spontaneous abortion. Of note, when we look at the composite poor pregnancy outcomes, these were similar across groups and uniquely driven by spontaneous abortion rates. But it is very important for us to contextualize that information because we have to interpret that spontaneous abortion rates with caution, given the non-legal status of abortion in many of the countries participating in the study. So we have to interpret these results with a little bit of caution. Digging in a little bit further, there were 157 births for women who had active cabotegravir, 31 live infants for prior cabotegravir, and 35 for no cabotegravir. We can see that the median gestational age was similar across the arms, and the birth weight in kilos was approximately the same across both. In terms of size for gestational age, we again see about 10% were designated as small. But again, contextualizing this information, as we can see here on the bottom, infant growth was similar across cabotegravir exposure groups. And that 10% of small size for gestational age in the active CAB arm was actually lower than previously reported background rates for similar populations. The 4 neonatal deaths that were noted in the active cabotegravir arm were considered by investigators to be completely unrelated to PrEP, and the 2.5 prevalence rate was consistent with the background rates of neonatal deaths, which ranged from 1 to 4% in that associated population. So our take-home points for long-acting PrEP is that in the Purpose 1 study in South Africa and Uganda, the use of injectable lenacapavir for PrEP in cisgendered women resulted in 0 HIV infections in the modified intent to treat population. Those injections were given on time in greater than 90% of participants, and adherence to oral PrEP with FTC-TDF or FTC-TAF was low. In the open label extension of HPTN 084, exposure to long-acting cabotegravir for PrEP resulted in maternal, pregnancy, and infant outcomes that were consistent with background rates, and that long-acting cabotegravir was well tolerated. Let's now transition from PrEP to talking about long-acting treatment. And we're going to be talking about the IMPAACT 2017 group, but here specifically the MOCHA study, which looked at a switch to long-acting cabotegravir and rilpivirine in adolescents who were living with HIV. And this was a multi-center, open-label, non-comparative phase 1 and 2 trial. And we're specifically going to hone in on cohort 2, which enrolled at 18 global sites, including the US, 3 countries in Africa, Uganda, Botswana, South Africa, as well as Thailand. And this included adolescents who were between 12 and 18 years of age with HIV and were virologically suppressed with a weight greater than or equal to 35 kilo. They were first switched to cabotegravir rilpivirine oral and then switched to injectable cabotegravir rilpivirine intramuscular at an every 8-week interval. The primary outcome, as you would imagine in a phase 1 or 2 clinical trial, was safety, adverse events or deaths through week 24. The secondary outcomes, we're pharmacists. We want to take a look at these metrics: pharmacokinetics, plasma HIV-1 RNA levels, the number of participants with virologic failure, and the adverse events as well. At week 48, the virologic success for the FDA snapshot was 97.2. All with a week 48 assessment had HIV-1 of RNA of less than 50 copies per ml. But of note, there were no cases of confirmed virologic failure, which was defined as 2 consecutive HIV-1 RNA levels of greater than 200. So no cases of confirmed virologic failure. And of note, when we take a look at pharmacokinetics, the median pre-dose cabotegravir and rilpivirine concentrations at week 48 were approximated to be what those would be in adults and were above the respective IC90s. In addition to these very, very promising results, all 140 participants responded to a preference questionnaire whether or not they preferred oral or injectable, and all 140 preferred long-acting injections to daily oral treatment. Taking a look at adverse drug events, we see that 34% of participants who received greater than 1 injection had an injection site reaction, but the vast majority of these were grade 1, and that they slowly decreased as time went on, significantly lower in week 48. 90% of injection site reactions were grade 1, and 89% of injection site reactions resolved in less than or equal to 7 days. We're going to talk about one final study within this section. We're going to look at the FLAIR substudy. So if we remember, FLAIR was actually one of the registrational clinical trials looking at cabotegravir and rilpivirine. This was originally done in treatment-naive patients who were switched onto oral therapy to get them undetectable, and then switching them onto injectable cabotegravir rilpivirine. And so this substudy looked at some patients who had been on cabotegravir rilpivirine for about 3 to 6 years. And so we were trying to see, can you give this medication, instead of giving it intramuscularly, can you give it subcutaneously? And in terms of giving it subcutaneously, which is a question we get fairly often, at least in my clinic, the formulation, volume, and injection frequency all stayed the same. The only change was that you gave it subcutaneous instead of intramuscular. Taking a look at pharmacokinetic concentrations, those were similar. including plasma exposures, so troughs and plasma exposures, excuse me. But the injection site reaction duration was significantly longer with subcutaneous versus intramuscular injections. And the acceptance and treatment scores were actually lower with subcutaneous versus intramuscular administration. And so because of these data, development for this specific regimen for subcutaneous will be discontinued. Whether or not we'll see other formulations looking at subcutaneous remains to be seen, and we await further results on that. So some take-home points on long-acting antiretroviral therapy. The data from the IMPAACT 2017 study continued to support using long-acting cabotegravir and rilpivirine in adolescents. The injection site reactions were the most frequent adverse events, but they decreased over time. And despite those reported injection site reactions, all participants responded to a satisfaction questionnaire, preferred the injections over oral. Finally, in the FLAIR substudy of subcutaneous injections, PK parameters were similar in participants who received the subcutaneous versus the intramuscular injections. But the subcutaneous injections were associated with longer duration of the injection site reactions, resulting in lower acceptability. And so development of that subcutaneous administration with that original formulation is no longer going to be pursued. And so now I'm going to bring my esteemed colleague in this conversation. We have a question here overall that now that we have another agent that's available for long-acting PrEP, and we're going to see more exciting data as time progresses with the PURPOSE package, what is the pharmacist's role in ensuring implementation of protocols and access to this new medication? I'll just quickly say that I know that it becomes very difficult for a lot of practices to implement injectables overall. I think we as HIV providers, we've had a little bit of experience with this over the last couple of years. But I think as we look at PrEP, which can be pushed into non-traditional settings like internal medicine or in the community pharmacy or any number of non-traditional settings, we have to have the infrastructure available. So I think pharmacists are going to be tremendously instrumental in making sure we bring that into a reality. Dr. Cocohoba, what do you think?
I couldn't agree with you more, Dr. Koren. I think that pharmacists are already playing a really important role in the distribution, setup, screening for acquisition of long-acting antiretrovirals inside of clinics. And so as PrEP distributes to beyond clinics, to other administration places, as you said, kind of community pharmacies, infusion centers, whatever we can envision is going to be the system where people can access their PrEP, pharmacists are again going to be the center of getting the medicines, screening patients for the medicines, and perhaps even having advanced practices where they provide people with the medicines are really their primary PrEP providers. You can see a day for pharmacists, coming in the near future to take care of those responsibilities. So I know, Dr. Koren, thank you for all of that data on long-acting injectable antiretrovirals. It's always exciting to see all of the new developments and the new information we're receiving about these.
Thank you very much to our faculty, and thank you to our listeners for joining in. As a reminder, to view the full program, Contemporary HIV Treatment and Prevention 2024, on the Clinical Care Options website, click on the links in the show notes for this episode. And to access all of our new podcast episodes, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.